Welcome to We Are Old, Get Over It, the podcast where we celebrate the wisdom of age and maybe a little grumbling too. Our guests dive into topics that matter most to us, from navigating the digital world to embracing new adventures and the challenges that hold us back. Join me for about 30 minutes of insightful conversations, honest reflections, and a whole lot of get over it attitude. So let's get started. Hi. Welcome back to our first season. I have the pleasure today of speaking to Annalise Smith from Avow Hospice, located in Naples, Florida. And hi, Annalise, how are you? You can say hi.
Hi, I'm doing great. Thanks for having me, Ken.
It's my pleasure. And I have a relationship with Avow. My mom was treated at Avow and she passed there, and the people there were wonderful. And for that reason, they were the first ones I thought of when I decided to do a story about hospice care. So I'm going to turn over to Annalise, who's had 12 years experience?
Yes,
in this field?
I've been at Avow for 12 years.
Okay. And I had 1 week experience in hospice care. So I'm going to introduce Elise, and I'm just going to let you go, and I'll have a few questions. And if you don't like the questions, you can just block me off, okay?
Okay. Well, thanks for having me, Ken. I really appreciate the invitation. Thank you, too, for sharing your personal story. A lot of times, the people that I meet, whether it be through an intentional connection like you've made by calling our office or just running into someone at Publix, it's through someone expressing their gratitude. They see my name tag and they say, oh my gosh, Avow helped my family member, my friend, and what a difference you made during a really difficult time. So thank you for sharing that positive feedback. Yeah. So hospice is a misunderstood type of healthcare for many people. Many folks haven't gone through the experience of having a close friend or family member go through the process of dying, and it is a process. And just as important as birth is, going through the end of life journey is an important one for us to support people so that they can have a comfortable and peaceful and dignified transition at end of life. So hospice is intended to do that. Here at Avow, we've been providing hospice care in the Collier County area for over 40 years. We were established in 1983 by a group of volunteers who recognized that there was a need for this type of care. And it was right around the time that the federal government was establishing the hospice Medicare benefit, which now helps to pay for hospice care. One of the most misunderstood aspects of hospice care is that we deliver hospice wherever the family or the patient calls home. So here at Avow, right through the window there behind me across the pond is our hospice house. And hospice house really shouldn't be called that because it's not a residential care facility. Hospice house is more like our intensive care unit. We only have 16 beds in the hospice house, and it's where people go when we have trouble managing their pain or symptoms in the home care environment. So we can take them to hospice house and give them a really intense, around-the-clock level of care. But most of the time, when we are able to bring people under hospice care in a timely manner, we can manage pain and symptoms very well in the home care environment. And so our team of staff goes to the patient's home, wherever that is. In some cases, it's in a beautiful penthouse on Gulf Shore Boulevard. Other times, it's in a nursing home or assisted living facility. And we've even treated patients who are living, unfortunately, in the homeless shelter or in a tent, in the tent city off of I-75, wherever the patient calls home. I mentioned the team. One of the unique parts about hospice care and the hospice Medicare benefit is that we deliver care through a team. So we have a nurse that is our nurse case manager, and she sort of leads the team, but she is accompanied by a social worker and a chaplain and a home health aide. And all of those people are assigned to the patient to make sure that we meet all of their holistic needs. So we're not just...
Let me ask you a
Sure.
question about that.
Sure.
For example, what you're talking about is very stressful, obviously for the individual, but also on the family. Mm-hmm. And some of those services that you're providing, and I only know from my own experience, are provided to the families also, correct?
Just as much, yeah. Okay. So I oftentimes I say that hospice is just as much for the family as we are for the patient, because you mentioned, Ken, your mom was only under hospice care for a week, right?
I believe so.
In a week's period of time, the home health aide might only have seen your mother a couple times. The social worker probably only saw her once. The chaplain maybe once or twice. Now, after mom passed away, we have continued services for the family through our bereavement programs, whether it be individual support or support groups. We follow family members for a full 14 months after their loved one has passed away, so that we can help them through all of the firsts. The first birthday, the first holiday season, the first wedding anniversary, all of those things that sometimes trigger some deep grief and loss responses. And we want to help people develop healthy coping skills. And so we offer all of those bereavement programs to the family. But even while your mom was living, we probably offered support to you. If you had your mom at home, we would have helped with bathing and personal care of your mother. The nurse would have taken care of making sure that the medications were ordered and prepared and administered at the right times. The social worker is helpful in referring to other community resources. If, for example, your mother was suffering from Parkinson's disease, the social worker might have referred you to the local Parkinson's Association for more disease-related specific support. If your mother had needed help during hurricane season for hurricane preparedness, the social worker might have helped to procure a location in the special needs shelter or those sorts of things. So all of these different people on the interdisciplinary team provide a different type of support and resource to the patient and family. But it's really their goal to make sure that we're treating the patient in a holistic way. So not just for physical needs, but also psychosocial, spiritual needs, and anything that they need to just enjoy the best quality of life for however many days they have left.
Okay. And you mentioned that when we first spoke, you mentioned hospice care, of course, which is what we were talking about. And then you spoke about palliative care. Could you explain that a little bit and what the differences are?
Yeah, sure. So where hospice is concerned, I talked about all of the things we do. What I didn't mention was how someone becomes eligible for hospice care. So
good point.
Again, your mom was only under care for 7 days. And I'm so grateful that we had a full week with her. But our intent is really to have 7 weeks or 7 months with a hospice patient instead of just that short period of time. One of our goals long-term is that we do enough education for the community through things like your podcast or, editorials in the newspaper or wherever we do our education to help people understand that hospice is not intended for the last couple of hours or days of life. It is for the last months of life. And so in order to qualify for hospice per Medicare guidelines, a patient needs to be not pursuing aggressive treatment. So they have decided that rather than calling 911 every time they're short of breath or having chemotherapy and radiation for the cancer, they're going to let nature take its course. They are going to not pursue aggressive treatment. That's first and foremost. And then once the patient has decided that, a doctor needs to certify that if all of these things happen and nature takes its course, we would expect the patient would pass away within 6 months. Okay, so it's a 6-month prognosis. Mm-hmm. So right now it's March. We would typically not say, do you have your crystal ball? Are you expecting to be here in 6 months? We might say, would you be surprised if your loved one would pass away before Halloween? Or would you be surprised if your loved one was no longer here come holiday season this year, and use that as a prognostication. But a doctor would have to certify or say that they feel that if nature took its course, the patient would be expected to pass away within 6 months. Many patients live longer than that. Again, we don't have a crystal ball. There's no way for us to know. And when that 6-month period comes to pass, if that patient is still showing incremental decline, or is still showing that they're getting worse instead of better, then we can continue to keep them on hospice longer than 6 months. If at the end of 6 months they appear to have gotten better and are doing better than they were, then we might need to graduate that patient and discharge them from hospice for a period of time, until some point in the future when they show a decline again. Now, for a patient who is not ready to forego aggressive treatment, someone, for example, who has cancer and is still sticking with a chemotherapy or a radiation regimen, they may be having pain or symptoms related to that need managing. And that's when we can do palliative care. That patient, because they're pursuing aggressive treatment, they may or may not have that 6-month prognostication or prognosis, but we could do pain and symptom management with them on palliative care. Palliative care is a place where we help people, or a delivery of care where we use the interdisciplinary team, just like in hospice, to help people that are living with longer-term chronic and life-limiting illnesses. So these are people, go back to the Parkinson's patient. Someone who has an early diagnosis of Parkinson's disease may live for 5, 10, 20 years with their Parkinson's disease, and they would experience gradual declines over a period of time. The palliative care team can help them anticipate and plan and prepare for those declines, so that when they happen, the patient and their caregiver are ready for it, and they can respond and not be in the hospital or having falls at home or uncomfortable pain and symptoms that we can well manage if we plan for them ahead of time. Okay. And then when the time comes that the patient may be ready for hospice and foregoing those aggressive treatments, the palliative care team can make that transition to hospice quick and easy and do it in a timely manner. Does that help?
It does. It does. I do have a couple of other questions. What does it cost?
Oh, that's a great question. So I mentioned Medicare.
Yes.
For hospice, the Medicare hospice benefit pays for a Medicare eligible person. They pay for hospice at 100%. Okay. Whether the patient is at home or the patient is at hospice house, Medicare pays 100%. For an individual who's not eligible for Medicare or doesn't have Medicare coverage, some commercial insurances pay for hospice, usually at a similar payment rate as Medicare pays. But in some cases, those commercial insurances may require a co-payment or co-insurance, like many insurances do.
I have a question about something else.
Sure.
What if somebody can't afford to pay?
So if someone can't afford to pay, and we do have people who are uninsured, we've served patients who are not citizens of our country and have no insurance or what have you. Avow is a not-for-profit organization, and we have made a commitment to our community that we will provide hospice care to anyone who is eligible and wishes to have it regardless of their payer source. So I'm actually, my primary job at Avow is as a fundraiser. We work very closely with philanthropic people in our community who have had a positive experience of their own and want to make sure that our services are available to everyone. And so we do have a charity care fund that is supported through donor gifts that allow us to do that. Where palliative care is concerned, Medicare also pays for palliative care, but they do not pay for it fully. And the reimbursements we have from Medicare and commercial insurance for palliative care only pays for about 20% of what it actually costs for us to deliver palliative care in the community. Where palliative care is concerned, it's under Medicare Part B. So a patient is subject to co-insurance and co-payments, and if they need to meet deductibles, just like going to any other physician specialty, a cardiologist or a dermatologist or what have you, a similar payment structure applies to palliative care.
I have maybe a sensitive subject to bring up. It was something I saw in a note that you sent me, actually. You said that there are myths about hospice care, and one of them being it's a place where they use morphine to hasten death. Mm-hmm. Did you run into that a lot? And explain. I'm sorry.
Yeah,
I'll let you go. Go ahead.
No, that's a great question. So morphine is one of the things that people just don't understand. And I am not a clinician, so I can't answer any very specific questions about morphine. But what I can tell you is I've heard from our doctors and our nurses that people usually come in one of two camps. They either come in and they say, I do not want morphine because I'm afraid I'm going to get addicted, right? Morphine is an opioid and people are afraid that they're going to become addicted. Well, what we usually say to those folks are, well, you're a hospice patient. You have pain or symptoms that warrant the use of morphine. It's going to be what's going to be most effective in making you comfortable. We only want to give you the medications that you agree to receiving. Patient is driving the plan of care. But in this brief period of time that you're going to receive morphine, if you do get addicted, is it really going to matter, right? This isn't going to create some long-term problem for you. And B, if it's meeting your needs to make you comfortable, who cares? But we also have other people that come in and say, I don't want to feel anything else. I want you to put me out, and I want you to help make this go faster. And that is not our job. Our job is to let nature take its course. Now, we don't want you to be writhing in pain while nature takes its course. We want to make sure that you, again, have a peaceful, comfortable, dignified death. But we are not here to hasten or hinder death. We want to let nature take its course while we keep you comfortable. So we very carefully dose morphine and all of the other medications that we administer and prescribe for our patients so that they have a comfortable level of being coherent and being able to engage with their family members appropriately and that sort of thing.
Do you have any stories you'd like to tell about families, not naming families, but anything that sticks in your mind that you would like to tell people about why they should use hospice or consider hospice, or experiences you've had or other people that you've worked with have had that would be beneficial to understanding, because we speak to seniors, better understanding what it is and knowing what's available in their community. And is hospice care available all over the United States? And are they all charity? In other words, are they all similar to yours where they're a charity?
Yeah, I appreciate you asking that, Ken, because what I will say to your Collier County listeners is you have the cream of the crop hospice option here in Collier County. Not all hospices are created equal. There is hospice in every community across the United States, but we're not necessarily all associated or affiliated. So again, Avow currently only serves Collier County, Florida. There is another hospice in our community that is a for-profit hospice. They are a branch of a national company that has locations all over the country. And typically, the way that a for-profit and a not-for-profit operate are a little bit different. Naturally, they have to report to their shareholders. For us, we're only reporting to our volunteer board of directors in our community. So we typically operate a little bit differently. However, we are all hospices following the same conditions of participation with Medicare. So there's a same basic level or standard set of services that we are all required to provide in order to maintain our hospice license. What I will tell you, and you asked about stories from families.
Yes,
some of my favorite stories are the stories about the things that we do here at Avow that aren't required of us. They're things that we choose that are above and beyond what the Medicare conditions of participation dictate we do. And those are things like our music and massage therapy. So Medicare doesn't recognize music or massage therapy as being important. But I've heard stories about a patient who has terrible anxiety. They are just really afraid of dying. Maybe even so much to the point that they're short of breath. They're having trouble capturing their breath. And we have all sorts of medications that we use to manage anxiety, typical depression drugs and that sort of thing, and even drugs that we use to manage shortness of breath. But I've seen or heard of patients that using massage and music has helped them to better relax and regulate their breathing so that they can manage their anxiety better than any medication that has been prescribed to them. I've seen massage and music being used together to do that. So patient is really short of breath and taking quick, short breaths. And the massage therapist and the music will start at a very rapid pace, maybe a high-paced song and some faster movements with the massage. And over maybe 10 or 15 minutes, the music and massage slowly or starts to slow its pace. And as they do that, the patient's breathing slows down with the pace of the music. It's absolutely amazing to watch. And it's those things that sometimes make the difference for that patient and the family who's at a loss for what to do to help this person manage their anxiety. And sometimes it's that simple music or massage intervention that does the trick. So those are things that the average caregiver wouldn't know how to do themselves.
I have another question, and maybe I was hallucinating or borrowing my mother's morphine, but not really. Okay, it was just a joke. But I kind of remember that you actually had dogs come in.
Oh, yeah. Yep.
Yeah.
So that too, Medicare doesn't recognize that as being important either. But yeah, we have volunteers is another really important aspect of our work. So we are the only Medicare funded type of healthcare that has a volunteer requirement. Medicare requires that a minimum of 5% of our direct patient care is delivered by a volunteer. So any of you out there that are looking for a productive use of some of your free time, we would love to have you seek out volunteer opportunities with us. And some people aren't for patient care volunteering. Others prefer to work in our administrative offices or at our thrift store or at our special events. But anyhow, one of our special groups of volunteers are our PAWS volunteers. PAWS is an acronym here stands for Pets Are Wonderful Souls. And a trained pet and their human counterpart make visits to patients in our hospice house as well as the local long-term care facilities. And they just make friendly visits for pets and licks and tail wagging that they bring cheer and companionship to our patients across the county. So that you weren't on morphine, your mom's morphine, Ken. You were remembering correctly.
Okay. All right. So to sum this up a little bit, there's hospice care everywhere. All you have
Yep.
to do is ask.
That's
If
right.
you're in a
Yeah.
hospital, if you're in a hospital, someone should come to you and say, "Are you
Mm.
interested?" Or say to the family,
If
"Are you interested in hospice care?"
if only that was consistently the way, Ken. I've got to say that your listeners should be their own best advocate. Anybody can make a referral to hospice. So, yes, the discharge planner in the hospital should be making the referral to the hospice. The physician in the hospital should be making a referral to hospice. The nurse in the hospital could make a referral to hospice. But people in the hospice or in the hospital are trained to fix people and send them home well, right? So
Yes.
sometimes those people in the hospital have a difficult time with the hospice conversation. Sometimes they don't, and they're very proactive. Other times they're apprehensive. So if the patient or their family thinks that hospice may or may not be an option, they should ask about it. They can ask one of those staff members in the hospital, or they can just call their local hospice directly. Google hospice in their area. Here in Collier County, of course, they should call Avow. Hospice will go out and offer a free assessment. A nurse typically goes out, well, here at Avow, a nurse always goes out, talks with the patient and family about their options. There's no commitment required unless the patient is ready to move forward. Otherwise, it's just an informational visit. And there are times when we find people aren't ready yet. And so we just educate them and let them know that they can contact us down the road when they are ready.
Another question. You say that what percentage of the people actually decide to stay home as long as they can?
Mm-hmm. So the majority of the care is delivered at home. Only less than 15% of our patients ever go to the hospice house. Most
Okay.
of the care we deliver is at home.
And a lot of times, if there's a two-story house here in Florida, most of the smaller houses are one story, so it's a little bit easier. Um, does hospice provide, or who provides the beds that they would use for themselves uh, or their families? In other words, if they can't get up a flight of stairs or
Sure.
their bed doesn't quite work for them.
Mm-hmm.
I don't know what other things, like a bed is one thing I think about. I don't know what other things there
Yep.
are. Are they provided through
Yes.
Medicare or through hospice?
Yes.
How is that done?
Part of the hospice's obligation, again, under the conditions of participation, are to provide durable medical, what we call durable medical equipment. So, in many cases, Ken, and if someone's in a two-story home, typically a hospital bed is provided by the hospice, and it's usually kept on the first floor.
That makes sense.
Sometimes patients, they set up a short-term room in a living room or a den or what have you. But we also provide, portable oxygen if a patient needs oxygen, uh, a wheelchair, a walker, a bedside commode. My father is currently under hospice, and the team just delivered him a shower chair. He was showering, standing up for the first 4 weeks or so while he was under care, and as his needs changed, suddenly he really needed that extra support in the shower, and so now he has a shower chair. But the hospice team, again, is responsible for recognizing those needs, assessing what is going to be helpful in keeping the patient safe and doing that. We also provide medications. So any of the medications that are related to the terminal illness and the care provided to keep the patient comfortable would be ordered and paid for by hospice as well. They're delivered right to the patient's home. No need for trips to the pharmacy anymore. We take care of all of that as well.
Okay. Let me ask you, as we're coming to the end of our interview, um, what what do you think is the most? Is there anything that you forgot to mention? Let's start with that.
Well, back to stories. Again,
Okay.
I'm not gonna tell a story per se, but one of the things we most frequently hear from families after their loved one has passed away is that they wished they had reached out to us sooner. So again, where you're talking about someone in the hospital, um, how do we get care? Don't don't ever think it's too soon, because if it is, then we get a chance to meet you and educate you, and we say, you're not ready for us yet. But don't wait until the 11th hour. It's very difficult for us to come into a situation when somebody is in terrible pain or having awful symptoms and control that in a short period of time. If we can get ahead of it and anticipate it, we can avoid some of those really uncomfortable situations for the patient. So I would say the first conversation you have with your doctor, and your doctor is delivering some bad news that you've got this problem that isn't going to go away, this big healthcare issue, it's fair for you to ask that doctor on that very first visit, do you think Avow could help? Because maybe palliative care would be a great support system early on, and then down the road when it's time for hospice, there'll be a nice smooth transition. Palliative care is also helpful for people who are newly diagnosed with difficult things to help evaluate the benefits and burdens of potential treatment. Okay. Naturally, the cancer doctor is going to always recommend chemotherapy and radiation, right? That's what you do to get rid of the cancer. But there are a lot of really uncomfortable things that come along with those treatments. And sometimes they're more burdensome than they are beneficial. And the palliative care team can really help a patient evaluate their options so that they can make informed decisions about their care. And it's back to being your own best ambassador or best advocate. Right. If you can be an educated healthcare consumer, you're going to be able to make really well-informed decisions that will allow you to be able to enjoy the greatest quality of life. You may not have as long of a quantity of life that you want, but all of your days will be comfortable and productive. And I think that's what most people want to have.
That's great. Thank you, Annalise. I think we can stop our interview now. Okay. I want to just thank you, and I want to thank Avow in Naples for freeing up your time so that you can speak to us about this very sensitive but important subject. And I always like to end the interview with a quote. So I go through internet, I find a quote. So it's hard to find one for hospice, but I did find one that I think will work. The author's unknown. It's a very famous author, unknown. It says, "I'm not afraid of growing old. I'm just curious to see what happens next." And again, I want to thank you. And listeners, you'll be able to see this anytime you want to. And if you're a younger person and you want to pass it on to your parents or some other relative, please do, because that's what we're here for, both Annalise and myself. Okay? Have a great day. Bye-bye.
Thanks for having me, Ken.
You're welcome. And that concludes this episode of We Are Olds, Get Over It. Thanks for joining me. I hope you found our conversation both insightful and entertaining. Remember, age is a journey, not a destination. So embrace the wrinkles, the forgetfulness, and the occasional tech frustrations with a good dose of get over it attitude. Until next time, keep laughing, keep learning, and keep getting over it. Ken out.